Hello, I'm Ash, and I'm a Stanford alumni, so thanks for inviting me back. I'm glad to be here. So at Caspar, we are addressing the long-term care market, which is a very large market which requires continuous care over time. And when we are targeting this market, the current models are all labor-centric. So the care delivery as well as the reimbursements are tied to the staff time. Essentially, the current solution result in very expensive and poor outcomes. At Caspar, we convert this model into continuous care with our AI-centric model, where the labor as well as the reimbursements and revenue are no longer tied to staff time. How do we do it? We are doing passive 24/7 data collection over months and days for the patient when they're living in their homes and facilities, and this lets us build complete 24/7 models of the human's behaviors, and this lets us do preventative and proactive care. And not only this, the FDA regulations are very supportive. There's a huge tailwind which changed after 50 years that such AI-driven models and monitoring solutions are now reimbursable with pre-existing codes. So essentially, for our clients who are the providers of such long-term care, convert their cost center into a profit center. A little bit more detail about how we do it. So we have sensors that are mounted, let's say one in a room. These are completely non-intrusive, no cameras or no variables. These are ambient sensor. They give us vitals, position of the people, and so on and so forth. And our core technology, which has 7 patents behind it, came out of universities and our own research, basically builds a model of that patient's data over months of their time, second-by-second data that is coming in. With this data, we are able to build outcomes, insights, and alerts that are not only interpretable by the clinicians, but they are also reimbursable. And it is very important while building these models to have them evidence-based, which is what our AI does. This is just not a vision. Over the last year and a half or two, we have deployed this solution across the US, from Florida to Hawaii, and from these facilities, across over 10,000 patients, we have produced outcomes more than 20,000 across 10+ health conditions, which range from immediate insights like falls or imminent fall, for example, a patient with a bed exit that shouldn't happen, to long-term conditions. And the very important part is that these conditions, due to preventative nature of monitoring, reduce the alerting time. We are detecting these conditions within seconds or days instead of months. We have also shown a huge reduction in false alerts with our solution. A little bit more insight about the technology behind it. So essentially, think about 10,000 data points per patient coming in, and our AI is comparing that against the actual data. Second by second, our AI is predicting what should happen with this patient. If it does not match the real data, it is maybe a problem. And our attention models look at these correlations over months of time to create an evidence-based recommendation. For example, in this case, that it could be a possible UTI. There are correlations related to patients leaving the bed to go to bathroom with respiration rate changes, and this becomes preventative care, which could be solved with an antibiotic pill rather than taking them to an ER, which is $3,000 in Nashville, where we had a bunch of these incidents at one of our sites. The cool thing about such AI models is that as we are collecting more and more data across more patients, as well as individually for each patient, these models improve over time. So to build this product, we have put the right team together. Our co-founder, David Cheriton, was the first investor of Google. He was the co-founder of Arista Networks. With him, we are building the right, reliable systems expertise. I myself did my PhD from Stanford in the area of AI. I was a professor at Cornell, but I changed from academia to business for the last 10 years. I have built a company called Catapult, which was AI applied to leasing models. So I have experience in building products out of it. Our engineering is run by Corey Gates, who built a company called iControl Networks, which was the security software, and did an exit. We are also have advisory board consists of doctors and MDs, including John Hamalka, who is the president of Mayo Clinic, Sanjay Agrawal, and numerous other people who are helping us solve the real problems. A little bit about the space. On the left axis, you will see point solutions in long-term care market. For example, measure the weight, glucose, or things like that. On the right side of the horizontal axis, we have to build comprehensive long-term models to provide that care. So you need to look at the large volume of data and understand how they work. On the vertical axis, you are looking at something that happens once you go to a doctor. They put down the notes or a scan, and a lot of good effort has been taking place, including some of the companies that you saw today. But for long-term care, we have to look at months and years of continuous data to be able to build the right solution. Our clients are providers, whether you are a senior living care provider, a care company, clinical care provider, telehealth company, please talk to us. And the way we work is we license our offering as an add-on package to a pre-existing relationship between the providers and the clients. There's a huge tailwind behind it. Our reimbursement model are based on several reimbursement methods based on RPM, RTM, which is tripling every year as we go forward, including in 2 years, there may be a software as a medical device codes upcoming. We are FDA Class 1 device. We are working on our 510K approval for Class 2. At the same time, the cost of the product is coming down substantially. Huge tailwind, huge opportunity, and we are a software company, so our margins are huge. And with this product, we have initially launched in facilities where we are increasing and tripling our revenue with the new reimbursement model. We are now working with aggregators of care, including some of the clients that I mentioned here. These clients have over 20,000 patients, in one case, 100,000 patients. Each of these accounts will give us millions in starting ARR, which can grow further. We are about to sign these details. But this market is big. Even if we look at our active conversations and 5% conversions, we can dramatically increase our revenue. And 1% of the market is a 200 million ARR market. So to summarize, Caspar is at the leading edge of a tremendous shift in long-term care. Our AI-driven model separates the dependency on the staff time and provides 24/7 care, and our patented AI is already live in the US, has produced more than 20,000 outcomes. And with our new reimbursement model, we are on the path to become a 200 million plus ARR company in 3 years. Thank you. Questions? Yes.
This is very impressive. I can imagine there's a lot of investment needed, in the home to capture all those data points. So my question is, what kind of sensors do you have? Is it at the cost of who, and do you have challenge with maintenance? Because typically that's where we find some of those solutions are a little bit more tricky to live.
Yeah. The good news is that the hardware cost reduces over time, became 1/5 over the last year. So as of today, we have a 15-day payback period on the cost of the hardware. Each sensor is about $50. A typical installation would be anywhere from $50 to $200 per home. But the revenue upside for our clients is significant for the next several years. And these sensors are based out of radar technology that came out from the automotive world. So they latch on to different frequencies from 10 gigahertz to 70 gigahertz to extract location, position, heart rate, and respiration rate with the help of our AI context. We have to subtract multiple people in the room, layouts, and so on and so forth. Yes. Sorry, go ahead. Yeah.
So do you move the data to some place to do the computation, or do the software runs on the sensors, and how does it work? I'm more worried about data movement and privacy here.
Yeah. Privacy is very important. We have a white paper on privacy preserving edge computing. It has to be HIPAA compliant and SOC 2 compliance. Generally speaking, you are doing some processing on the edge and moving the data in a HIPAA compliant manner to the cloud to do further processing, and then you're managing the right users across the board.
So you're computing some on the sensors and some you move to the cloud.
Some data has to be processed on sensors because it is computing on a microsecond basis, but at a second basis, the data is uploaded to the cloud, whatever is relevant. There is some optimization based on the relevance of the data. But the cloud has to be HIPAA compliant and follow those regulations.
Hi, I'm Vivian, Payer VC. I have a question on reimbursement and payers. So I see you sell to a lot of long-term care facilities, assume maybe drives more revenue, that's great. How do you think about sort of the long-term goal to sell to payers and potentially capture the percentage of savings that they could get from not going to the emergency room?
Yeah, exactly. So this is why we are raising investment. Today we are raising basic first level of reimbursements from some of the codes. We have huge value based on our conversations in the value-based care space. So we are talking to renal care, where detecting UTI early could avoid hospital readmissions. We have preliminary conversations with our clients how to roll it out, but that's on our roadmap.
Thank you.